Welcome to Pediatric Dermatology Part 2. We'll begin with atopic dermatitis, which is also known as eczema. It's quite prevalent in the pediatric population. About 5% of the kids are going to present before they're 5 years of age, and 50% of them are going to develop the condition by the time they're 1. And so this makes for a miserable infant. They're miserable because of pruritus. They have terrible itching, and they don't have the ability to actually scratch themselves. As the child gets older, the ability to scratch, of course, becomes very common, and this increases the risk for a secondary infection in the form of cellulitis that we've already discussed. Eczema is worse in the winter due to the dry air conditions, and typically improves in the summer, but this depends on the geographic area. When you consider Southern California has its summer in September and October, where our humidity is extremely low and the temperatures are very hot, our kids with eczema are suffering due to the dry air. When we look at the distribution of skin lesions, it depends on how old the child is where you can anticipate seeing the changes. From the newborn all the way through age 5 years, the typical areas are on the face and the extensor surfaces of the arms as well as the chest. So we start out with erythematous papules, and sometimes they're small vesicles that when you push on them, there's clear fluid. Later, these dry out and become scaly, and with repeated scratching, they will be hyperpigmented. And the older children, their lesions tend to be focused in on the antecubital and popliteal fossa areas, and this would be in the bend of the arm as well as behind the knee. In addition, they have lesions on the wrist and hands. So the goal is to try and avoid the triggers so that this child can be as comfortable as possible. It's important that parents are taught that eczema is not caused by a food or milk allergy because there's a lot of misconceptions about this. We can control the itching by using Benadryl or Atarax, but you know what the side effects are. In the younger child, you may not have the fatigue that you're going to see in the older child. You're going to see the opposite reaction. You'll have a child who's miserable and can't sleep. In the school age and the older child, we have to be careful when we give it to them because you don't want them falling asleep in school. We want to try teaching the child and the parents to avoid scratching as much as possible. Now, this can be decreased by cutting the fingernails and by keeping those nail beds clean. However, when they really have a lot of itching, they're going to grab anything they can put in their hand and use it to scratch. So we need to tell them the importance of leaving it alone. And the best way to control itching is to hydrate the skin. It's preferred that these children take a bath in a bathtub in tepid or warm water rather than taking it in a shower because this moisturizes the skin better. They need to avoid hot showers as this reduces the water or the moisture that's actually in the skin. They must avoid using fragranced skin products and laundry detergents. In addition, we want them to avoid using the dryer fabric softeners, and that can be either the liquid that's put into the washer as well as the products like Bounce and Snuggle and whatever else is out there because these are very irritating to the skin. Shampoo is another trigger for eczema. You must include all of this information in your patient education. And in order for you to educate them about the products to avoid, you need to elicit the history in terms of what are they using. There are going to be some children who need to apply topical steroids. We use low potency for the face and moderate to strong potency for other areas of the body if the disease is severe. And remember, a little bit goes a long way. If the child is using steroids that are topical, you must include sun sensitization in your patient education. They need to avoid being out in the sun, wear a hat, wear long sleeves, because skin and topical steroids decrease the pigment in the skin. Pause the video long enough for you to write down the URL of this website, and it has product recommendations to treat the skin of eczematous children. Our next topic is contact dermatitis. Now, so in the little ones, most likely they develop contact dermatitis because of exposure to urine, feces, and the variety of products like diapers and panties. They can also react to different ointments that parents put on the skin. Candida is fairly common in the diaper area also because Candida loves warm, moist, dark areas. And what better area than the diaper? For these children, you need to get the history from the parents in terms of what is the type of diaper they are using and how often are they changing. Because the newer products tout the benefit of them is you have dryness against the baby's skin. But if the parent only changes the diaper once or twice a day, the urine and feces are still being on the skin surface. Our treatment goals for contact dermatitis is to keep the area as clean and dry as possible. When we're washing, we either just use warm water or water and a mild soap. We can use barrier ointments such as A&D or Desitin. Both of these are over the counter. Some hospitals have their own product called butt cream. That's right, BUTT cream. And we apply that after diaper changes. For children who have fungal dermatitis, we will apply Mycolog cream or ointment, which is a combination steroid and antifungal if it's particularly angry, or simply nystatin cream, which is antifungal. Remember when you apply these to go beyond the border of the lesion because Candida, i.e. yeast, spreads laterally, outwards. So you want to get all that area so that anything that's starting to spread is killed. We want to change the kid's diaper frequently and avoid plastic pants for the parents who are using cloth diapers. If possible, we want them to leave the area open to air. So when the kid's going to sleep, just have the diaper underneath them and leave it open to air. You can cover the top half of their body, but leave the buttocks and genitalia open. And this is only going to be for infants and toddlers. Now, there are other areas that also can develop fungal dermatitis. So in addition to the diaper rash, in the neonate and infants, they can have thrush. And we treat this with mycostatin oral suspension. And we'll give this 4 times a day. And you need to paint the baby's mouth with it. Adolescent girls develop fungal vaginitis. Immunocompromised children can have thrush. They can have dermatitis in the axilla, in the vagina. It can be anywhere. It can even be in their bloodstream. So are children with cancer, children who've had transplants and are on immunosuppressive agents, and asthmatics who use inhaled or long-time oral steroids are at risk. There are a variety of other forms of fungal dermatitis that occur in childhood. So we have tinea capitis, and that is of the head, tinea corporis, which is on the body, tinea pedis, which you know as athlete's foot, and then we have tinea cruris, which is also known as jock itch. So you can see the variety of lesions of the capitis corporis and pedis on this slide. We treat these with topical or oral antifungal agents. We can use Griseofulvin, which is oral, We can use Lamisil or Lotrimin, and this is going to be for smaller lesions. The tinea capitis is not going to be treated with topical agents. We're going to use either griseofulvin or fluconazole. But do note that there are resistance patterns being reported to fluconazole because we're using it so widespread. For resistant and severe infections, micafungin or capsofungin given IV over an hour may be needed. So in addition to the medication, you need to discuss hygiene. So wash the linens, wash the child's clothing, wash the hairbrushes in hot soapy water. They may also use bleach on hairbrushes and combs. And then for the kids who have tinea pedis, I recommend that they spray the shower and the bathtub after the child gets out with a Clorox bleach type solution so that it is not transmitted to other members of the family. And this child should not walk around barefoot in the house either. So this ends part 2 of Peds Dermatology.